discussing with the one and only Noah. Noah, I learned so much from you, so I'm so excited to co-discuss with you. How are you doing, friend?
I'm doing well. I'm super excited to be here. Thank you for inviting me. Today I'm going to be a little bit delirious because I'm on nights and I only had 4 hours of sleep today. But it'll be fun. I'll be fun. Yes, I'm excited to discuss today.
I'm always delirious and I had more hours of sleep, so welcome to the club, my friend. We'll have delirium Wednesdays. How about that? Big shout out to Mariana and now we're in for describing and doing teaching points, and the one and only Jazz is presenting a case. So if you can get the board up, Jazz, tell us a little bit about how you've been doing, friend, and maybe get us started.
Been good. Just been busy, but I feel like this case should be a good one. I saw this about a month ago, and I feel like I had some good teaching points.
Always learn so much from you, friends. So I'm super excited. Whenever you're ready, take it away.
Awesome. So before I begin, there'll be a total of six aliquots. The sixth one will have the diagnosis, and then I have some teaching points afterwards, just to set the frame. So for the first aliquot, this is a 77-year-old female. And if I'm speaking too fast, if the scribe can just send me a message and I'll slow down. 77-year-old female that presents with several weeks of left-sided neck pain and shoulder pain. I'll pause there just for initial discussion, and I'll give more information after.
Neck pain and shoulder pain. That's a interesting chief complaint, which I feel like I haven't seen that often. And when I'm faced with those out of the box chief complaints, I usually go back to the basics, right? And I think about anatomic causes for pain. And just imagine an arrow going through the neck and the shoulders and just going layer by layer. So if we have a skin problem, could it be like initial manifestation of zoster? Could you have like a skin condition that's causing pain? If we have a soft tissue problem, could you have like an infection, like Ludwig's angina? Less likely given the several weeks of pain and no other inflammatory symptoms, at least in the first aliquot. Thinking about muscles, neck pain and shoulder pain and muscles seems, reasonable. 77-year-old female. I'm thinking about polymyalgia rheumatica, myositis, vasculitis, like giant cell arteritis. Thinking about nerves. Could she have like a nerve compression, like cervical myelopathy causing neck pain, shoulder pain? Maybe she has some associated neurodeficits. And yeah, so very broad. I think what's going to be really telling will be the accompanying symptoms because pain on itself is very kind of non-specific and many problems can cause pain. What do you think, Sharmin?
That was beautiful. I love that shooting the arrow and thinking about anatomy. I feel like, yeah, anatomy is like such a perfect schema to fall on if we don't have like another approach to it. And that's often how I think about it too. I'm not going to repeat the amazing differential that you laid out in terms of like thinking about the different compartments. The one thing that I would just add is that, and also thinking about referred pain as well. So like diaphragmatic irritations, cardiovascular symptoms oftentimes can like have a referred pain to like upper extremity. And 3 weeks is a long time. Well, oftentimes with ACS, we hear people have like jaw pain, neck pain, oftentimes referred pain. And then also like kind of thinking about the joints themselves, like, from like septic arthritis, thinking about our no misdiagnoses. But oftentimes like in all comers, when you hear like neck and shoulder pain, often musculoskeletal osteoarthritis, those things tend to be the base rate. However, we always like want to make sure if she's like presenting to the ED, we're not dealing with one of our like no misdiagnoses, which is like kind of like vascular etiologies, infectious etiologies as well. All right, Jazz, back to you.
Awesome. Great initial discussion. So, provide you guys some a little bit more history. The patient describes the pain as more of a sharp stabbing pain that she feels like she can really localize it, and then will radiate to the left shoulder. However, she's been also dealing with like left-sided shoulder osteoarthritis and has been seeing orthopedics. And like a couple of weeks before coming into the hospital, she ended up getting a left-sided steroid injection of the shoulder, which did not help her symptoms whatsoever. She decided to come into the hospital because even though this was persistent for several weeks, she kind of felt like the pain was getting worse, and just was kind of, I guess, getting tired of the outpatient workup and just wanted answers faster. She denies headaches. She denies fevers. She denies chest pain, shortness of breath, no abdominal pain, no nausea, no vomiting, no numbness, tingling, no weakness that she's endorsed on either upper or lower extremities. She's never had pain like this before. Her past medical history is notable for type 2 diabetes. Uncontrolled, her last A1C was 9.2%, which was done 2 months ago. Her diabetes has been complicated by neuropathy and retinopathy. She also has history of glaucoma. In 2021, she was diagnosed with renal cell carcinoma, but then underwent a radical nephrectomy with no complications. And she had like rescans 6 and 12 months apart, which were negative for any recurrence. She also has history of post-ablation hypothyroidism and CKD, which recently has progressed to stage 4. It was usually stage 3. And she also has history of hypertension. As for her medication list, she takes both glargine insulin and short-acting Lispro for her diabetes. She takes amlodipine and labetalol for her hypertension, and she takes levothyroxine for her hypothyroid state. With her social history, she has been a never smoker, never has drank any alcohol, lives with her husband, and does not have any pets in the house. And that is the end of this article.
Thank you for this aliquot, Jazz. A lot of information. So what sticks out to me is that she has pretty bad, type 2 diabetes with tons of complications. And this goes along to what Sharmin was saying about the vascular risk factor. So this patient is a patient who's a high cardiovascular risk. So I would be curious to know if her shoulder pain is triggered by anything. So let's say she's walking and then she has the shoulder pain, or is it triggered by the movement of the shoulder? Yeah, what do you think, Charmaine? I'm still processing all the information.
Yeah, no, I think that's a really, really good way of like kind of thinking about like whether the actual pathology lays in the shoulder or is kind of a referred pain. Oftentimes, referred pain are pretty constant, doesn't change with movement. If it's the osteoarticular or like muscle movements, it can exacerbate it a little bit more. And I think like the diabetes, as you mentioned, significance, thinking about like both vascular etiology and also a risk of infection that it pertains. And oftentimes like when we do something to an area of pain, then you have to think about two different pathways, right? Like that steroid injection it did not address the pain, but can it be nidus to now introducing a source of infection into the joint, for example, and now we're dealing with another process on top of a chronic issue that she's having? Or was it just a benign thing that we can just take it as a like, oh, the pathology that she has is not within the joint, that was not relieved or changed by steroids? I think like, the fact that fever, neck pain, the other things that she had no fever is like meningitis and encephalitis. Again, like, the time course doesn't quite fit for that. I'm curious, Noah, what do you think about like their past medical history, except with diabetes? Anything else that in there that jumps out to you that might be related?
Yeah, so she has this past history of the renal cell carcinoma
Mhm.
back in 2021.
Mhm.
We could have, abdominal problems being referred to the shoulders.
Mhm.
So that's one way that I could connect the dots. It is reassuring that she apparently did the appropriate follow-up with the scans and both were free of recurrence. When you were talking about the steroid injections, I remember the case that I think Rabi shared within our group in the Academy VMR, which was a complication of steroid injections, intra-articular steroids, it was sort of like reactive arthritis to the steroids injection. So
Mhm.
she has 7 weeks of pain, and she was dealing with OA before. When did the pain get worse? Was it like immediately after the steroids, a couple weeks after the steroids? Did the pain get worse before the steroids and then the steroids didn't do anything? So I'll be curious to like really narrow down and establish this temporal relationship between the intervention and the progression of her pain. Yeah, what do you think?
Yeah. No, absolutely beautiful. Yeah, like whether are we dealing with the recurrence of her cancer is basically one of the questions that we're asking, whether it's like intra-abdominal or is it like metastasized, and are we dealing with like a bony pain of some sort that now she's like presenting. The stabbing nature of it is interesting to me. I don't know quite what to make of a nature of the pain, like whether that is like more like a vascular involvement or is it like worse with movement. And I think this is like where like a really good exam is really helpful to see if, as you mentioned, if there's any point tenderness, is there any asymmetry, is there any worsening with like movement, passive or active. So that I think also going to be helpful. And I think with her you just have to have a high degree, given the degree of like past medical history she has, you just have to be worried about something more systemic going on that is kind of like presenting as this kind of like neck and shoulder pain. Or perhaps it's just like, regular meal like OA or like some muscle strain. And that we can also treat. But I think like, the exam, vitals, and labs are going to be a little bit more informative in us like helping us figure out like, oh, is it even worth zooming out of the shoulder and go more towards like a general, like a more systemic issue? All right. Yes, back to you.
Awesome, thanks. All right, so just to answer some of Noah's question about the progression. So she didn't really feel like the steroid injection made it worse. She just kind of felt like, it didn't do any benefit for her pain, and then continued to notice the pain regardless of the steroid injection. And I forgot to add a piece of information from the previous Eloquat. I'm sorry. She had a screening colonoscopy 6 months ago, which showed a tubular adenoma, which was removed. So that's one. And then in terms of the third aliquot, so vitals essentially stable. Her blood pressure was mildly elevated at 150 over 90. She was not tachypnic. She was not tachycardic. I believe her heart rate was like 92. And she was satting well on room air, like it was like 98%. Her exam was notable for mild tenderness to palpation in like the cervical spine, spinal processes. I would say probably around like C2 to C4. But outside of that, she didn't really have anything else that was abnormal. Her strength was 5 out of 5. The next range of motion was intact. Did not have any reproduction of pain in cervical flexion, extension, rotation. Um, her upper extremities had 5 out of 5 strength. Sensation was intact. Her lower extremities, 5 out of 5, intact sensation as well. Cardiovascular, pulmonary, abdominal exams were all normal. In terms of her basic labs, in terms of for her CBC, she did have a mild leukocytosis at 12.9, predominantly left shift, so neutrophil predominant. She At baseline has anemia of a hemoglobin of 10. However, when we checked it on admission, it was 8.1. Her hematocrit was 25%. Her platelets were normal at 236. And her basic metabolic panel was notable for a mildly hyperkalemia at 5.2. She did have a little bit of a drop in her bicarb to 20. Her creatinine, baseline creatinine is around 1.8. Several months ago, it was actually 1.2 until she progressed to CKD stage 4. But then on admission, her creatinine was 2.1. Her glucose was elevated at 300, and her CRP was elevated at 44, ESR at 54. Her LDH was normal at 239. And I will stop there. This outline.
Sorry, Jazz. Can you repeat the CRP again? I think I missed it.
Yep, sorry. And I'm sorry again if I'm speaking a little too
No, no,
fast. So the
you're doing great.
CRP is 44.
44. Gotcha, gotcha. Okay. Thank you. All right, now we got some more information. What do you make of the exam and the lab?
Yeah. So the exam was reassuring that her vitals are normal, and then, mild tenderness palpation over the spinal process with normal range of motion, no pain. So here's how I'm putting this case together. I'm thinking about, when we have a patient with lower back pain, like what are the red flags, right? So advanced age, history of cancer, pain that's non-resolving. And I think we can kind of transpose those red flags to, upper back pain if we're considering that she has pain over her spinal process. She is elderly, she has this history of cancer, she has this mild tenderness to palpation, and then her labs, they have some subtle abnormalities that hint at a more systemic process, right? She has like this unexplained leukocytosis, this slight anemia, this elevated inflammatory markers. And I think it would be very easy to overlook those findings in a patient who was healthier at baseline, but just because of her history and her age, I'm more concerned about it. And to be honest, I think, I'll pull the trigger on imaging now. I want to see what her spine looks like, what her shoulder looks like. And I'm hoping it's negative. I'm hoping it's nothing there. What do you think, Sharmin?
Oh, love it. Just out of curiosity, what image would you get? Would you get CT, MRI?
Yeah, I don't know. I think getting a MRI. It depends on the setting, but I think I'll get an MRI because I'm concerned about spinal cord involvement, especially with this sharp stabbing and radiating pain. So I'd get an MRI.
Yeah, I think that's absolutely fair. And I totally agree with you that, I'm more concerned now with kind of her lab abnormalities and also the tenderness she has in C spine. And, it would be interesting, like, there are shoulder movements that if it's like any radiation down the shoulder or to the arms, like Hawkins and stuff, that you can try to reproduce if she's like able to do those movements. That is there any like radiculopathy due to that? But then again, the question becomes like, uh, uh, especially with like neck and shoulder pain, like they're like right next to each other. So are they like same pathology causing it? Are we dealing with two different pathologies? So like if we separate it out for a second and just like focus on the neck with the spinal tenderness, in someone who has like seems a bit inflamed, again like with increased age and everything, sure, like inflammatory markers can be a little bit up or in a setting of CKD. However, again, like like she has just part of control diabetes. She has like a bunch of like kind of metabolic risk factors. Well, this is someone that I might pull the trigger to actually get blood cultures too, thinking about like if she has any low grade bacteremia that caused like an epidural abscess of some sort. Is that like she had the steroid injection? So I would like get blood cultures in this patient, and I totally agree with you imaging it, like whether it's like a disc herniation. The other thing, I'm sure. I'm so sorry, Jazz, if I missed this. Like, if she had any history of trauma to the neck, like recent accidents or anything like that, sounds like she didn't. If there's like a recent trauma, I sometimes like start with a CT because, like, you can just like catch the bony abnormalities, any compression fractures and stuff like that. But if you're at any time like worried about like the spinal cord itself, I think like MRI can give you both information. The other thing to, again, like with her history of cancer, I'm worried about like um and like any pathological fracture that like in a setting of like bony mets that she might be experiencing. And C-spine, I just have mad respect for C-spine. If there is like any concern, I have a very low threshold to get imaging to further evaluate it, just because of the enormity of everything that goes through it. And the other thing to always like take it back and like what else, as you did like initially in your first article, what else, what other real estate is in the neck? A lot of thing is. So if the the MRI comes back negative, is there something else going on that she's just experiencing it at like a spinal tenderness? But I don't think we're there yet. The hemoglobin drop, I don't know what to do with it, to be honest, from like 10 to 8. Other than just in the context of like kind of worrying about like occurrence of cancer or worsening CKD, is that just like EPO related? But I think that's something that I would not lose sight of and just control that added to the problem list, work up to get a better sense of like what type of anemia is this, asking about blood loss, all of those usual questions that we ask, but get the iron panel, get a better sense of like where that anemia is coming from too. Any other thoughts, Noah, from you?
No, I love it. I think one thing that it's really it's making me think about this case like harder is the time course, right?
Mhm,
Several weeks. I think
mhm,
if this was something that happened more acutely,
mhm,
it would be like a different frame or more chronically. So I think, that's the thing that's making me pause the most, the 7 weeks of pain. If she had like 1 week of pain, she was inflamed, it's a more convincing story for like a bacterial infection versus like more chronic pain developing and then some neurodeficits after a few months. Maybe I'll be more concerned about, bony destruction, mets, cancer recurrence. Yeah, so I just want to highlight that this is something like this subacute nature is making me pause. But I'm curious to hear more, Jazz.
Awesome. I'm loving this tandem of Sharmin and Noah. You guys are doing a great job. For this next alpha, it'll be a short one. Um, the alk phos was elevated at 175, but did not have any other abnormalities on the LFTs. Um, Blood cultures were sent after we got the CT neck result, and it was cooking. The CT neck showed a pathological fracture of C3. Because of this pathological fracture and concern for a lytic lesion behind it, we did get a pan scan of this patient. A CT chest was negative for any nodules or any lung masses or anything like that. The CT abdomen and pelvis did show a questionable nodularity of the pancreatic tail. We also obtained SPEP with capital M, the free light chains, given the progression of CKD and the anemia. However, they both came back normal. And I'll stop here for this element.
Yeah, I love the workup. I was thinking I was gonna suggest the multiple myeloma workup, especially given the age, anemia, CKD. It's recommended that we get both the SPEP, the immunofixation, and the serum-free capital lambda and the serum-free light chains. Increases the sensitivity because you can have like a negative SPEP and a positive immunofixation and vice versa. There's a good episode, I think it was from Core IM, about this workup. And then she has this pathological fracture. What can it be from, right? Can it be from the renal cell carcinoma, which we think she's cured from, or can she have a de novo cancer? Does she have a recent mammogram? I think she's out of the age range for screening, but I'm curious to see if she did get it like when she was 75. Yeah, I'm thinking about other cancers that like bone mets and are baseline very common. So lung, she's a never smoker. Breast, we don't know about the mammography. Multiple myeloma, the initial workup was negative. And then the renal cell carcinoma and this nodularity on the pancreatic tail. So this is where I am right now. What do you think, Charmaine?
Uh, yeah, I totally agree with you. Those are the cancers I was running to my head. The prostate, sorry, the prostate, no, the nodular was the pancreas, not prostate. The pancreatic, I was like, prostate cancer. But that is interesting. I think maybe that is also worth investigating a little bit more, running by GI, getting it maybe a dedicated study, that whether that is like something benign appearing or something that is worth perhaps getting a biopsy of to make sure that that's not kind of the primary site of it. But again, I think you're right in thinking like that is probably less likely. Um, I yeah, I think like with renal cell cancer, you can have recurrence of renal cell cancer as well, and I think with that a history, background history, that would be the thing I'm most concerned about. But like thinking about like pathological fractures as well, uh, the other thing is like again like indolent infections can cause it, like people who have really bad osteoporosis with very little trauma that they might not even know can get pathologic fracture. So I think like holding a little bit of space for those other as we like going down the malignancy tray to make sure we're not missing anything of that sort, I think would be helpful too. I think like the fact that alk is also elevated uh, makes a better cause for like a bony-lytic lesion that is most likely malignant. However, I live in a fear of like, not wanting to miss another diagnosis, like an infection or something. So uh, that is just kind of like my own bias that I have. Any other thought, Noah, before we hear more from Jazz?
Yeah, no, I love it. And I think a good clinical reasoning exercise is if we fast forward to the end of this hour, right? And then Jazz tells us that we're completely wrong. It's not cancer, it's not infection. What else can it be? And I was just thinking with the alkaline phosphatase being high just reminded me of like Paget's disease.
Mm-hmm.
I don't think cervical would be like a common localization for that, or other, primary bone cysts, which are benign but can cause pathological fractures, just to include in the differential diagnosis. But I'm right there with you. I'd hate to miss an infection in this paper for sure.
That's a great thought, Noah. That's a great thought. All right, Jazz, tell us more.
All right. Great discussion. So, just to answer your question, no, a mammogram last time she had it done, I think it was 2 years ago, and it was normal. And she's hadn't noticed any lumps since then. So this aliquot will have an MRI of the C-spine, which redemonstrates the C3 pathological fracture with associated osseous retropulsion, contributing to moderate to severe spinal canal stenosis between the C2 and C3 region. There was also a mention of extension of a tumor into the epidural and neural foraminal stenosis, contributing to severe left neural foraminal stenosis. And then because of this nodular pancreatic lesion and the prior history of a tuberous adenoma, GI was consulted. They recommended an MRCP for the pancreatic nodularity, which essentially just everything else in the abdomen was normal, and they just re-demonstrated the nodularity of the tail. They also did a colonoscopy, and it only showed a couple of hyperplastic polyps, but no other concerns for cancer. A bone scan was also done, and outside of that C-spine lesion, there was no other lesions that were mentioned. Um, And I think that was the main part of that was the main part I wanted to mention, the fifth aliquot, and the next aliquot will reveal the final diagnosis.
So we did see a tumor in the MRI.
Correct, in the C-spine.
Yeah, I think we're doing our due diligence. We're investigating all the different types, the possible primaries, right? I think one other that comes to mind, I saw a very sad case during residency, was melanoma with mats to the spine. I think that's worth doing, like a skin check. But I'm concerned that we're gonna have to just go for the mass, do the biopsy, and tissue is the issue, and hope that the histological diagnosis, like we can make the histological diagnosis by that. I'm very glad that they did, the investigation for the GI possibilities. I wasn't even remembering about the adenoma, so I'm glad they did that. What do you think, Sharmin? What else can it be like this tumor?
Yeah, I totally agree with you. Tissue is the issue. To be honest with you, I don't know if my illness goes for like some primary bone cancers is thorough enough. But like this invasion into it makes me more worried about metastasis than like a primary bone, just given her background history. But again, I think the question is like, is there kind of a localized bony disease that she's having, or is this a metastatic disease? I'm still worried about like, that background history of RCC. I might just be anchoring on it, but that still would be the one thing I would be worried the most about. Melanoma is such a great thought, Noah. It just sneaks up on you and it goes in very random places. And I think like with melanoma, like they tend to bleed more. But I think at this point, I would ask neurosurge or like neuro IR whether they would go after her so we can get some more data. And then I think like waiting for that pathology to come back, and in the meantime, just like supportive the therapies for her to make sure her pain is controlled. Um, and I think like for now, we've just like kind of are mostly focusing on the neck pain, but like making sure the shoulder pain sounds like from all that we know so far, I mean, it might just be something separate that is the OA that is acting up, and these two are not related. But that's another thing to not lose track of, like given her complaint. But yeah, I don't know exactly what type of malignancy would be, but that would be my biggest worry, although I still have my eyes on that pending blood culture that is still not resulted yet.
Yeah, Jazz did say that it didn't result, so no
You
wonder.
know, so all right, Jazz, back to you.
If it puts both of your minds at ease, the blood cultures came back negative. So if you want to make some final comments before I share the last aliquot.
My mind is definitely more at ease. Thank you so much for that, Jazz. Yeah, yeah, can't wait to hear what happened.
Awesome. So I think not the challenge, but the thing that the thought exercise we were having with this patient was like, when we got the MRI results was like, okay, yes, this concerning for malignancy, but where, right? Where is it coming from? And it was a great teaching point for the residents that I was working with, because they asked, because I just like you and Noah, Sharmeen, I had on my differentials, could this be RCC? And the residents asked, well, the RCC was 3 years ago and was removed surgically, and there was no recurrence. And I think it was a great teaching point. So I'm sure if they had those questions, I'm sure others had the same question too. So what neurosurgery ended up doing was actually they did tumor resection. And they also followed that up by a spinal fusion with laminectomy from C2 to C7. So they actually ended up doing surgery on her to remove the tumor. And the reasoning why is they were also concerned for RCC. And in RCC bone mets, you need a wide resection, or else even the smallest amount of particles can then remain and metastasize again. So the pathology report eventually came back concerning for renal, clear cell RCC, the same exact one that she had in 2021. Which was, pretty interesting considering that, there's no other evidence of any other abnormality other than this like nodular pancreatitis, which honestly, in retrospect, feel like it was more of an incidental finding.
Mhm.
Um, and a couple of things like, the things that I relayed to the resident team and then I learned myself from my own research is, these cancers, especially RCCs, they have these microscopic residual disease, these tiny little microfat. And I looked up the first surgery report. It seems like at that time it was stage 4
Mm.
RCC, which means it involved the perinephric fat. I'm not sure if it passed the Garota's fascia or not. But if it involves the fat does have blood supply, and it's possible that the microscopic RCC cells actually like went into the blood supply. And interestingly, these RCC cells can actually lay dormant in bones and other tissue for a very long time. And RCCs are known for recurrence 5, 10, and even 15 years of nephrectomies. So just because a patient is cured does not mean that they can have recurrence. Interestingly, not always does recurrence mean poor prognosis in patients with RCC. They actually do respond pretty well. Um, RCCs are different types, but clear cell is the most common subtype of RCC. And then there's 3 main paraneoplastic phenomenons that you need to keep in mind. The one is the one that we all know about is the erythrocytosis or the polycythemia. The other one is hypercalcemia. And then the other one is actually non-metastatic cholestatic liver dysfunction, also known as Stauffer's syndrome. And it presents with like cholestatic liver injury. Um, Her alk was obviously coming from the pathological fracture, and that's where another teaching that happened in this case was, like how does the bone lytic lesion? How can we talk about that and like different types of cancers? So multiple myeloma was on the differential. Noah, huge kudos to you for mentioning Paget's. That was discussed as well, and neurosurgery was actually considering that as well at one point. Melanoma was also considered, but she didn't have any other suspicious lesions. But multiple myeloma. So the next question was that the patient asked, like, what is the probability that I'm going to heal from this bony destruction? And that was a question I didn't have an answer to. So I looked it up, and it was actually very interesting. So bone healing from lytic lesions, multiple myeloma, 67% of patients with lytic or like multiple myeloma leading to a bone lesion, 67% recover.
Mm.
RCC to the bones, about 44% recover from that lytic lesion. Breast, 37%. And interestingly, lung, 0%.
Wow.
So I asked myself, why is lung 0%? Why do those lytic lesions don't recover at all? And this was actually pretty fascinating. So not all cancers, when they go to the bone, have a same um, like spectrum. They have different type of spectrum how they kind of cause damage. And how lung attack the bones is it's predominantly all osteoclast activity. And they do this via PTHRP and tumor necrosis factor, and it leads to avascular necrosis of the bone. So there's essentially no blood supply left to the bone, and it basically makes it not recoverable. Whereas RCC, if maybe from screams of step 1, it can release VEGF, and that leads to angiogenesis. So even though it is predominantly osteoclast activity, it does form angiogenesis, which then can help with reforming of the bone of those lesions. In multiple myeloma, Robbie taught us that it's one of those situations where it typically does not lead to ALK phos elevation unless there's a pathological fracture. So the reasoning behind that is it's very similar to the RCC. Rather than angiogenesis, it actually leads to destruction. It doesn't lead to that much of a destruction of the osteoblast activity, and it's a gradual osteoclast. So it's not enough for you to have an ALK phos elevation unless you have a pathological fracture. And the reason why multiple myeloma bone lesions respond to treatment much faster is because they don't have, like I said, the osteoblast activity is still on, and the osteoclast is, once you treat the multiple myeloma, the osteoclast kind of activity goes down. So I thought this was a great case for things that we're going to see commonly. Um, and like certain things that were like the patient asked me questions that I didn't have answers to. I was like, okay, this is great. I need to know the answers for this. So even though you guys got the diagnosis very early on, it was a great case to like kind of go over the basics of lytic lesions and why certain bones repair, of why some cancer lesions repair faster than others. It was just I nerded out on this, and I just wanted to share this nerdness. So I'd love to know what your thoughts are.
Jazz, you're so incredible. I mean, I'm just like smiling ear to ear listening to you teach. We're so lucky to know you, and you're such a wonderful doctor. Like, that was just absolute beauty. I learned so much. Thank you so, so, so much. Neil, what are your thoughts?
Yeah, I loved, learning about RCC. 10, 15 years, that's kind of crazy. Can you imagine like having a full resection and then 15 years later you find out you have the same cancer just laying dormant? That's crazy. And Jazz, I'm so inspired by you because you're like so curious. You're always asking why and trying to understand the mechanisms behind it. Your patients are very lucky to have you, and you inspire me to be a better physician. So I'm super glad to be here today. And I had a ton of fun discussing the case with you, Charmin.
Yeah, right back at you, Noah. You're amazing. Yeah, Jazz, you're just was fantastic teaching. Versus mine is like, yeah, RCC is very sneaky. It just comes back. I just like often think about RCC as like TB of the malignancy world, that it just like hides there, sneaks away, and then it just like bam comes out whenever it wants to. But that was like such a great explanation and demonstration of that, and I really loved the lytic lesion part of it and like the VEGF versus like the destruction. And I'm like, well, I did not know that. I didn't even think about that. So Jazz, you're so awesome. No, you're brilliant, my friend. So great. So great learning from you. And thank you so much, Jazz. This was such a really rich case to just like make sure we have a good grasp of the fundamentals, and which I really love. And Mariana, thank you so much for scribing. Now we're in mic to you for the teaching points.
Actually, I am doing the teaching points today. So after like
Oh,
all of
so sorry
that
about
jazz,
that. Thank you,
no,
Mariana, for
no,
doing the
no,
teaching points.
don't worry, don't worry. So Jazz, after that, I'll try to summarize my teaching points because nothing will be as brilliant as you told us. But I'll try to be very brief here. So we started the case thinking about neck pain associated with shoulder pain, and we started to go layer by layer. We thought about skin problems or soft tissue problems or muscle problems or something in the nerves, like just like nerve compression or myelopathy. And then we also discussed joint problems, just septic arthritis. And Charmaine also mentioned that we can't forget about referred pain because we could have something happening in the diaphragm or any cardiovascular diseases like appearing with neck and shoulder pain. So we have to rule out that. And also, when we found out that this patient had many diabetes complications, we again mentioned that this patient has a high cardiovascular risk. So conditions like an MI should be ruled out, and also infections. And also, it's very important in this case to characterize the pain because if it's exacerbated with motion, we could have something simple, just like OA. But this patient's pain did not get better with steroids. So we started to think about a chronic issue, maybe malignancy. And we started to get even more worried with this patient when we found out that this patient had a past medical history of renal cell carcinoma. So we started to think about maybe a metastasis. And then we also discussed red flags for back pain. This patient is 77. She has history of cancer, small tenderness to palpation. The pain did not get better with medication. So these are all red flags for back pain. And then we also think if the neck and shoulder pain, they are associated or they are just like different problems. We emphasize how important it is to rule out infection in this case. Blood culture was very important. And then we figured out that this patient had a pathological fracture, and at this moment we started to discuss further metastases. But it's also very important to think about osteoporosis in this patient. And something very important that I learned today is that increased alk-Phos make us think more about lytic diseases than just osteoporosis. And this patient ended up being diagnosed with metastasis of renal cell carcinoma, and we also discussed this etiology. And Jazz taught us that a lot of paraneoplastic phenomena that can happen with patients with RCC, just hypercalcemia, non-metastatic cholestatic liver dysfunction, and increased production of erythropoietin. So with that, I finished the teaching points. Thank you very much, Sharmin and Noah, for discussing this brilliant case. Thank you, Jazz, for bringing this case to us. Thank you.
Was brilliant, Mariana. Thank you so much for summarizing all the teaching points so beautifully. Noah, Jazz, Mariana, Norvin, everybody, thank you so much for joining us. You're all the best. We'll see you next time. Bye.